when I hear you guys talking now, I'm hearing about two separate aspects of hemophilia care. One is, I'm going to give you something because you're bleeding. You've had an injury, you've had surgery, something. And the other is, I'm going to give you medication because I don't want you to bleed in the first place. So how do you parse this out? What's the difference here, and how do you approach this?
Yeah, so there's two approaches, just like you said, and for the severe patients with hemophilia, severe Hem A and B, and the severe types of von Willebrands, the typical recommendation, particularly for hemophilia, is prevention of bleeds, right? We know that they're going to have somewhere between 20 to 30 bleeding events per year. That's obviously unacceptable because that can lead to significant problems. And so the strategy is that, and it's been recommended over the last few decades, is to start regular infusions of factor replacement for Hem A and B and some forms of severe von Willebrands in the first 3 years of life, or before or immediately after the first joint bleed. And a lot of us are, we're waiting for data, but a lot of us don't like to wait for first major bleeding events.
I was going to say, that would make me uncomfortable. We don't want joint bleeds. I heard you say that.
Yes. And that's the general recommendation on the data, but obviously we have personal feelings about how we don't want our patients to suffer from bleeding events. But there are challenges. If it was something like a pill or something they could easily take, no big deal, but these are IV therapies predominantly, and I know we'll talk about emerging therapies. And so the average age for prophylaxis in hemophilia A is about age 2. And so that's a huge time point, 24 months in which they're at risk for life-threatening bleeding events. And so it's a problem. And then obviously when they do have bleeding events, they'll use that same factor therapy to treat the bleeding events at different doses. And again, that's where we send separate scripts for their prophylaxis and then for their on-demand acute bleeding treatment, which may be a different dose.
Clearly the doctor isn't, or the nurse, isn't going to be at home every morning to give an IV dose of something.
Sure.
And it's a 2-year-old.
Yes.
I mean, let's get real.
Yeah.
This is a 2-year, this is why I do grown-ups. Putting an IV in a 2-year-old every few days?
It's emotionally taxing as a parent as well, just seeing that. And this is a group of people that have learned to adapt, and they understand that predominantly the women in the family take charge, and they said, well, if he can't do it, my aunt can do it, or she can do it. Even we see this in the Amish community. All the women know how to stick those children. Even the conditions that they have, it's pretty amazing. And so, and if you've ever seen this, we have these bleeding disorder camps in which they learn how to stick themselves for the first time. It's very emotional to watch this because their mothers aren't nearby, and so they're just standing there with a butterfly trying to stick themselves, and everything is just silent while they do that. It's very emotional, and they get something called a Big Stick Award, and these kids remember this the rest of their lives. When they're 40 years old, they're telling me about it. So
I'm glad it's your job.
Yeah.
And I don't mean that facetiously.
Yeah,
it
it's
bothers
tough.
me.
It's
to see these little kids, but the option is so horrible.
Yeah, up until recently, the option was there was no other option. It's either you treat it and you prevent it. This is good for the child, but you know that this is emotionally taxing on them.
Right. So let's talk about the treatment options. Now, these are the standard old-fashioned options, right? Let's go over some of these. We've got the concentrated factors and prothrombin complex. Walk me through some of this.
Well, currently today with the concentrated factor 8 and factor 9s, there's essentially two different types. There's the standard half-life products, and then there's the extended half-life. Okay. And those are pretty much the standard of care today. There's also the activated prothrombin complex concentrates, which are generally used for patients with inhibitors. Cryoprecipitate, I have not seen, to be honest, but we do use desmopressin or DDAVP or Stimate for patients who have kind of mild factor 8 deficiency. And then Amicar or Lysteta, which is aminocaproic acid or tranexamic acid. Those are used, again, sometimes for some of our milder patients. And sometimes surrounding dental procedures or menorrhagia in women. So those are pretty much the standard treatments.
How do you store this stuff?
Well, refrigerator is a lot of it, but some of the products, some of the older products are stable at room temperature for 3 years, and so we just have to kind of let the families know or the patients know that if you're going to be traveling, some are good for 3 months out of the refrigerator. So if you're going to go to Europe on a trip, you know, congratulations for going on a trip, but you don't have to refrigerate your factor. Don't worry about that.
That doesn't apply to fresh frozen.
No.
You got it. That's cold.
Yes,
right?
yes.
And cryo.
Yeah.
You don't see cryo anymore? Or you've never seen cryo?
Well, I've heard of it. We don't dispense it to patients out of the pharmacy.
So that typically comes from the blood bank,
Right.
and unfortunately, and thankfully, we try to avoid the use of those products. Typically, they're given when we haven't identified a patient. For example, a baby had circumcision bleeding. They don't know what's going on. They think it's hemophilia, but they don't know which type, and so somebody says, well, I'm going to give cryo or plasma. And so we've been trying to avoid that use because there potentially is a risk for inhibitor development.
You know, there's something on this list that shocked me,
Yeah.
which is we were using fibrin glue.
Yeah.
Still use fibrin glue.
We still use it.
And I didn't know, because I don't talk to you guys all that often, but surgeons were using it with the best of intentions, was developed with the best of intentions, but suddenly you're seeing antibodies.
Yes, yes. And you see this with like a bovine preparation.
Right.
You can develop these unusual antibodies that present later, directed actually, you know, to factor V and some other factors, because it's what we call a dirtier product. It's not as clean. And so thankfully there are recombinant forms of these things, but they have these little, you know, topical thrombin. We still use that a lot for circumcision bleeds, you know, and you always tell people, if somebody's bleeding, put pressure to it. Sometimes the most basic thing happens. Instead of watching it, thinking that you're waiting for some magical medication, your hand will help stop the bleeding as well.
You know,
So-
I learned that in medical school.
Yeah, yeah.
Pressure.
Pressure.
Of course, it may be an hour.
Yeah, you're gonna be there a while, but yeah, so.
And walk me through this too. Basic hematology 101. You've got platelets.
Yep.
They form a plug.
Yep.
But you need the other factors to stabilize the plug and then form a permanent stop. But
Yeah.
will the platelets work right away, or is...
Yeah, so when there's any damage to blood vessels in the body that exposes collagen and that creates currents that change in the blood, and so what happens is von Willebrand factor helps those platelets stick to the surface. It's sort of like building your basement, and von Willebrand factor is sort of like the mortar. So if you don't have enough of it or it's dysfunctional, it doesn't matter how great your first floor is, right? So that's the base layer.
So von Willebrand, no platelet action here.
Yeah, so the platelet adherence or adhesion can be affected, and then other critical factors happen. So coagulation, which we all learn, people forget to say it happens on a platelet surface. That part of it gets left out. And so you need that platelet surface for factor VIII, factor IX, for thrombin generation. And then there's clot retraction, and then there's the cross-linking of fibrin. And then the whole point is to approximate the wound and then allow time for it to heal. And so what happens in hemophilia and von Willebrand's, those components aren't as good, and so guess what happens? The plug just falls off. You start bleeding again. So you might stop it, they come back later, and they're bleeding again.